So then we shall go on to our next speaker, Dr. Meenakshi, who's going to be talking on managing paralytic strabismus, which I believe is one of the most challenging areas for a strabismologist. I don't know whether I need to be corrected on that. So let's hear from her.
Good evening. I thank the organizing committee for giving this opportunity. My talk is on management of paralytic strabismus, and doing it in 7 minutes is going to be a tough task, but Amrita has made it little easy. It's an incompetent strabismus, which can be partial or total. And in incompetent, it can be all these types: restrictive, paralytic, neurogenic, myogenic, or spastic type. And it can be at the various levels: supranuclear, nuclear, internuclear, or infranuclear. I hope the slides are visible, and I'm
Yes.
audible. Yeah.
Yes, yes.
So coming to the management, to start from the history taking, and these are some of the red flags when you are seeing a nerve palsy. And then there is an associated vision loss, headache, trauma, fever, proptosis, or any vestibular symptoms, and any absence of systemic disease. And the evaluation, I'm not going into the detail, except that you should remember to do a refraction and a fundus for torsion. And diplopia and HChat is a must. And FDT and FGT is also a very important part of the testing process. And we should not forget the evaluation of a sensory status, whether because that changes our whole plan, whether there is any diplopia or whether there is any stereopsis, or all that have to be checked. And not last but the least is a comprehensive neurological examination. And some of the photos where patients usually have an abnormal head posture, just to make sure that they don't have a diplopia field, to ensure a diplopia field. But some can adopt a other head posture also, so that the distance between the images increase, so that we can ignore the image. Another important thing is we should check the ocular motility examination, check for saccades and pursuits, the doll's eye movement, ductions. Always ductions are better than the versions, so we may miss the nerve palsy. And then vergences, especially in INO. FDT, a small point is it is restricted in a case of mechanical restriction, whereas it is free in a muscle palsy. And same way in FGT, it is the other way around. FGT, mechanical restriction, it is forced dentation is normal, whereas in muscle palsy it is absent. So another important thing is torsion. We have to see in the either indirect or direct. This I have shown a direct ophthalmoscopy photo, where it is usually normally 7 degrees below the optic disc, and it is when the eye is extracted, it is below this plane, and in torsion it is upward. It is in a direct ophthalmoscopy picture, is the exact opposite in the indirect. A comprehensive ocular examination for checking the pupil, and a comprehensive neurological examination. Coming to the investigations, always streamline your test. All the blood counts, sugar, BP, all that have to be done. And a mandatory indication for neuroimaging is multiple cranial nerve palsy, or if there is no systemic cause, or somebody's mic has to be muted.
Could you please mute everybody?
Intracranial mass when you are suspecting, or any associated field defects, or any signs of cerebellar or other this thing have to be imaged. And in the pediatric age group, it is always better to image rather than leaving it, taking it for granted. Always image whenever you are having a pediatric nerve palsy. Medical management is very important. In general, control all the systemic conditions. And optical therapy, it's we can use patching to prevent alternate eye patching to prevent amblyopia and to prevent diplopia, or ground glass can be given. And smaller deviation, and if the deviation is stable, prisms can be given. Either Fresnel or clip-on prisms can be given. So coming to the important topic of indications for surgical therapy, which I will be concentrating on. The main thing is you have to have stable deviation, at least 2 consecutive charts showing no change, and at least it should have been there at least for 6 months. And systemic factors have to be controlled. The primary goal is a primary position alignment and alleviation of the abnormal head posture, and elimination of diplopia, and not last but the least is the enlarged the binocular single vision field. So coming to the third nerve palsy, Amrita has made my job easier. Check for the residual medial rectus function. If it is crossing the midline and if it is present, then we can go for a maximum recession and resection procedure itself. And no, but if it is not there, there is no point in flogging a dead horse. If there is no medial rectus action, then you can go for a lateral periosteal orbital fixation or globe anchoring to the medial orbital wall. Here we are showing a photo where we have done congenital third nerve palsy, where we have done a supra maximal lateral rectus resection 14 millimeters along with the medial rectus resection, and the eye is almost straight. So we can, even with a simple procedure, we can get away with it. And this is a pre-op and a post-op picture where we have where we have disinserted the lateral rectus using a non-absorbable suture and then fixing it to the lateral orbital wall 5 millimeters posterior to the periosteum. One thing we have to remember is you should close the muscular septum well, otherwise it will get reattached. So that is one important point. This split lateral rectus muscle for oculomotor palsy, a lot of variations are there. Even Dr. Rohit Saxena in the recent article where he has done a cross fixation of this. Here, this is a pre-op photo. It is a traumatic third nerve palsy, and you can see the pre-op and then the post-op picture where the eye is straight. Where I'm sharing the video where we have first done the posterior PTSO also. So when you do a PTSO, it helps in two things. It will help in when you are passing the suture also, it will be easier, and you will have a better effect also. So use a gauze, what is it?
And you have 1 minute remaining.
And then you can do this thing. Here, this is PTSO being done, and you partially split the lateral rectus into 2 halves, and then the most difficult part is passing it under the recti muscle and the obliques. So use the prefix sutures and then take it underneath the inferior rectus and the inferior oblique, and then attach it along the superior and inferior to the medial rectus muscle. One difficulty is we can have is when you are using the doing the superior oblique. That is why we use a PTSO. It makes our job much easier. So usually we perform on the affected eye first, and rather than the fellow eye. Fellow eye we can think of when you are having an aberrant regeneration, so that it has an effect of fixation due to suture. Coming to the fourth nerve palsy, the commonest cause of acquired vertical strabismus. So one thing we have to remember is it can be congenital. So whenever there is a large vertical fusion amplitude, and you should get the family album tomography, because suddenly patient will say at the age of 30 that he's having diplopia, but it can still be a long-standing. So based on the old photograph, we can find it. And in an acquired, usually they have a characteristic head tilt to the opposite shoulder, and Park's three step test will help in identifying it. And always think bilateral when you have a positive Belchowski's, when it is onto the both sides, or a chin down or a V pattern, and then esotropia is there, or we have a 10 degree, more than 10 degree of extortion. This is there in algorithm, is there in all the books. One thing I just want to mention is always check a superior oblique. How is the superior oblique, whether it is very lax or not, especially in congenital this thing. No point in just directly weakening the inferior oblique alone, because if you don't do this thing, tuck, it will not help in making the eye straight. And a bilateral, you check for the torsion, less than 10 degree or more than 10 degree, more than 10 degree, go for a Harada-Ito. I'm not talking on the grading of the inferior oblique because another person is already tapping on it. And this is a video showing a superior oblique tuck. Always do a guidance exaggerated force duction test, and go along the temporal border of the superior rectus. One tip in the tuck is when you are we should remember that we have to take only half of the whatever measurement we want when we are taking the measurement with the caliper, so that we don't land up with an overcorrection. So this is what you have to measure, half of it, and then tuck it. So this is the suture being taken, and after attaching it back to the sclera there close by, one thing we have to do is do a FTT again. You can do an adjustable in this also, and finally you check force duction test has to be done, or a passive duction testing can be, traction testing can be done, and make sure that you don't do cause an iatrogenic superior oblique palsy. So in a passive traction testing, you are when you pull the globe up, it should at least should be at the level of the medial canthus. So with that, we will know whether it is this thing. Want of time, I'm skipping this Sarada video. So coming to the last one, sixth nerve palsy. You can have even following acute ET, following polio drops or viral fever, all that we have to remember. Or it can be a keratoconus fistula. So that is why imaging is very important, or it can be following a raised ICT. And this is one case report where you can have a combined mechanism. This is 3 years of, this is a pre-op photo at 2 years of orthophoria. At 3 years, the patient had presented with mesotropia of 6 months duration, and it was partially corrected. And then when we neuroimaged, it turned out to be a medulloblastoma, and the child is orthophoric now with just simple hyperopic correction alone. So this plays the importance of doing a neuroimaging. And botulinum toxin plays a very important role in the treatment of sixth nerve palsy. It's here we have shown a pre-op and a post-op photo where it's just injection into the medial rectus gives the good correction. Transposition is being well taken by Dr. Amrita. Usually we do augmented, we have done, and this is a video showing an augmented Amal sheet. I'm just showing the one side alone in the superior rectus, where the main thing is, as you said, the FDT has to be done. So it won't work if your FDT is positive. So split the superior rectus well, and 4 millimeters we have taken mark and done a resection, and the suture is taken at 4 millimeters. And the main thing is you have to disinsert at least 12 millimeters or up to 14 millimeters, so that we can split the tendon and split the muscle and bring it and place it along the spiral of Taylor. So this is the video where we have placed it. I'm just showing only the superior rectus. So, or we can just do a single muscle transposition, as Rohit told. That also gives very good result. Or cross action, like instead of just placing at the level of the medial rectus, lateral rectus, we can go and cross fixate it also. Nishida, I'm not talking. This is one of our case where we can see the pre and the post-op where it is giving good results. At 1 or 2 cases, we got an overcorrection also. One case we had an overcorrection. The one most important advantage is we just had to release the suture and everything was back to normal. So I'm not showing the video. So it still remains a challenge because we are not able to give a diplopia field in all the cases. And one important thing is we have to identify the etiology, as some can be life-threatening, and then subsequently treat with suitable modalities. So it can range from observation to surgical intervention. Thank you.
Thank you very much, Dr. Meenakshi. That was a amazing talk. And Dr. Veena, would you want to take a question? We have a number of speakers. So
yeah, I have only one question. Dr. Meenakshi, when the patient has diplopia only in extreme cases, do you prefer sectoral patches?
Only in extreme cases, I would prefer not to do a surgery, and you can go for prisms or patching.
Okay. Thank you.
thank you. Thank you very much.